All right. Well, I'd like to welcome everyone to the December Interprofessional Education meeting for the School of Health Professions at National University. Tonight's speaker is Dr. Kevin Lachapelle. Dr. Lachapelle has been one of our adjunct faculty for many years in our department, even all the different numerations and names of the department. Kevin has been with us. He's the CEO of the San Diego Community Health Center. He's a leader in the San Diego area in healthcare, and he's a author of many professional works, as well as a global advocate with over 30 years of experience in healthcare. Under his leadership, he has implemented many innovative initiatives, such as the Refugee Health Assessment Program and the Mobile Health Unit to provide accessible, culturally competent care to underserved communities. With a background in law enforcement and global humanitarian work, Kevin brings unique insights to the healthcare policy, advocacy, and community health. Kevin regularly presents for the U.S. Department of State's International Visitor Leadership Program. As a founder of Power Mentor, he champions human rights and empowers marginalized communities worldwide. And I know Kevin's mentored many, many students as well as young adults and young people in the San Diego area. Kevin holds a doctorate of education, a master of public administration, and a bachelor's in business administration. His work is driven by compassion, transparency, and a commitment to improving lives locally and globally. I think you'll enjoy his presentation today. I'll turn the floor over to you, Kevin.
Well, thank you so much. It's good to be here to connect with everybody and collaborate. And it was interesting when I was asked for this subject matter because we're going through so many things in healthcare right now, very specific to this. So, first of all, for me, kind of my leadership style is very mission driven in our approach to care. And so we are a federally qualified health center and dually funded also with Indian Health Service. So we also serve a third of our patients are federally recognized tribal members, urban Indians that receive care as well. And so we see so much the importance of interprofessional collaboration in the health system. And then for us, especially, we have a lot of language barrier challenges because we also serve as the sole organization for the Refugee Health Assessment Program. So language line has become very custom, but also the better approach has been to identify people from these specific communities so that they can not only be great translators, but also understand the culture. So that's been great. Our goal is improving patient outcomes and safety and reducing staff burnout. We're seeing that huge with providers especially, but also in nursing. And then improving quality care. And my background before was in large health systems. So I started my career after law enforcement was at Scripps Health, which is the second largest in San Diego, and then Sharp Health. And then I was at Press which is the largest contractor for CMS, and then at Kaiser. And so when I was approached about this community health center, this is the first time that I didn't even know what an FQHC was at the time when somebody approached me and asked me if I'd be interested in helping kind of help this clinic that was kind of facing some serious challenges. So it's been an amazing opportunity. It's been a little over 6 years now. And one of the things that the principles that we've tried to implement because we faced so many challenges, one of them was during COVID, after I arrived, just a few months after COVID hit. And so, that brought its own challenges. It was interesting because anecdotally, I remember when we finally were able to take the masks off, there were many staff that didn't know who other staff were because they had only seen them wearing a mask. And so it was common for people to ask someone, "Hi, can I help you find something?" And they were like, "No, it's me. I work here." And so it was just kind of interesting. Um, but the things that we've tried to instill, because we have a very diverse workforce that actually matches our diverse patient population, and we have all the generations. And so there is certainly challenges in communication with the different generations as well, but also understanding that shared purpose and aligning all of our goals, that transparent communication, but also understanding accountability in data-driven decisions. And for me, the big thing is really trying to have a spirit of humility and continuous learning because We don't know what we don't know. And healthcare, especially now with all these federal changes, we're facing things that we, had never encountered before. So we've put this image here. It's become very powerful in our organization. And what this stands for, the model, connect, involve, is as leaders, we try to model the behavior that we want to see in our teams. But if we're not modeling it and we're asking them to do it, it just doesn't work. And then connecting people together and being able to connect our teams and connect with them in unique ways, um, so that they know we know who they are really, not just what they do, but who they are. And I remember when I worked at Scripps, there was an executive that would always do rounding, and that was a big deal for everyone to do rounding. And he would say, hey, so and so, you're doing a great job. And then people would all talk and say, I wonder if he knows what any of us actually do, because he always just says, great job. And I never forgot about that. And so this connecting is also being able to actually share with people, hey, I heard yesterday what you did with that patient. That's incredible. So that people know that we actually know exactly what they're doing for their greatness and how they're impacting our patients. And then involving everyone. We kind of say, like with the patient, nothing about the patient without the patient. And we say nothing about the staff without the staff. So we're learning that in the same level that we engage our staff was in direct correlation to how they engage our patients. And so that's been something that's been really important. The other thing is we've had to implement care without barriers, because we've noticed that some of the younger generations, because they're not used to having healthcare issues, and so they're not much users of the healthcare system. And so they don't necessarily think it's a big deal for someone to have their care delayed, a few weeks or a month. And so we want to remove any barrier we can to prevent timely and compassionate, any barriers that are preventing timely and compassionate care, because we believe delaying care is denying care. So those are some of the tools that we've kind of implemented that have been helpful. Um, and what we're seeing from staff is, like, for example, I put together a CEO breakfast. So once a month, the teams, all the departments get to choose someone. And then when they come to that meeting, it's kind of a troubleshooting meeting where we all strategize and talk about what are some things that we could improve. But it's not coming up with problems. The kind of rule is, if you come up with a problem, you have to help design the solution. And so that's worked very well. And then we've, used data to identify if things are changing, so that we can give accolades and let people know that what you did had this much impact. And so, and I'm sharing all of these because infused in all that is us trying to develop a communication strategy, because I think even many of us fall into this. For example, if I get a phone call from someone and they like to talk a lot, in my head, I'm like, oh, just send me a text. Because if they send me a text, I can go back to it and go say, what else were they saying, or whatever it is. And so we're seeing that young people definitely struggle with face-to-face communication. And we're seeing a lot of that. We do census-based surveying. So every patient gets a survey when they leave. And we're seeing that a lot, where patients are feeling like that they're not connecting with them, or in some cases, they may not be empathetic. And then when we talk to the staff, they had no idea that that was the perception. And so we're seeing a lot of those things. And then it's also looking at, within healthcare, we all know the silos that we have, that we've also, every time we have a monthly all staff, we will see that everybody sits at the table where their department is. And so we've had to come up with tools where we can play games where it gets everyone to actually go mingle with other people. And then people start seeing, wow, I didn't even know that person, and they work, in this other department that I do interface with. I just only talk to them on the phone. So some real life examples on our team, the federal changes that were coming out this year early on, it scared a lot of people. A lot of our staff were very fearful for a lot of reasons. Patients were afraid they were going to lose their insurance, things like that. And so what we did was we figured the communications is going to be key. So we began being careful what we share. In other words, like we would have people call us and say, hey, ICE just came to our clinic. They raided our clinic. And then later they would call and say, sorry, that was a false alarm. It was just Border Patrol drove by in a van and we thought they were coming for us. And what would start happening is people were losing credibility and also catastrophizing instead of really being able to have information that has been vetted and is accurate. And so we started putting out kind of alerts, and it would be like an executive order would be passed, and we would kind of demystify it, put it at a layman's terms. What does this mean for the country potentially? What does this mean for California? What does this mean for San Diego? And what does this mean for us? And what does it mean for you? And that kind of really helped a lot because staff felt like they were engaged and they were a part of it. And then we would have a means of people being able to respond, like on a Google Forms, like on a survey, where they could talk about why are these things concerning and what are some things we can do to mitigate this. So, for example, we have 60% grant funding. People were worried we were going to start losing grants because of the Doge coming through. But instead of, saying, hell no, we won't go, that kind of a thing, we decided let's really start telling a story of our patients. So, for example, our SDPI, which is a diabetes program, let's find some really good success stories that talk about clinical outcomes that resulted in actually saving money for the health system because people didn't have to use the ED, things like that. And we started using that when I would take trips to DC. I would be armed with that so that we could have a bipartisan approach to help both sides understand, you know, what this means if some of these programs go away. Why would this increase cost in the healthcare system? Things like that. And we would engage staff and patients in that. We would do video vignettes where we would let our team that does the social media interviewing patients and staff talking about, how are they feeling, but also really looking at making sure that we have clean data to support what the story is that we're telling. So those things have worked, really well. Um, the refugee health assessment program was catastrophic for us when I don't know if you remember, but we had to ramp up when we got this contract with the county. So we had to hire multiple providers, and all of a sudden on a Friday, an executive order was passed, and we got a call on Monday morning, which I knew was coming from the county, and it says I already knew all flights were halted. And so immediately we were in a dilemma, and now we have to lay off providers. And everybody knows how hard it is to recruit providers for one, but also the scare that starts putting into everybody else. So because everyone's connected, we feel like the connections are really strong in the professional communication side, everybody understanding each other. We had one provider that basically came up and said, actually, I think I might get deployed. She was a reservist in the Navy. I think I might get deployed. Um, you know what? Maybe I just get deployed and then you don't have to lay off that other provider. That was huge to have people see each other interacting to help solve problems, to mitigate the impact that that could have on someone, losing their job. And that happened with a couple other roles as well, which was, I thought, really amazing. The other thing is, with the refugee health program, we also had people afraid to come to the clinic thinking that somehow something was going to happen to them. So again, we had to use our team that are from those communities and arm them with right information and have them go out and actually connect with people, which was kind of a challenge in some senses because, again, some of the younger generation are shy in some respects of being able to go out and have conversations, critical conversations with people. And so we were able to do some of those things that really helped the refugees understand that no, you're fine coming here. And we can also bring our mobile unit out to you, all of those different things. So that was, really interesting how those intricacies worked. And what I'm basically really want to get at is all of these things that were trials like COVID and then these federal changes ended up bringing us together closer because we allowed it to, where we tried to facilitate that from where that could happen. The other thing would be, it used to be that no one wanted to be interviewed for the news because I have a lot of connections with news. And so we were on the news a lot. And I really wanted to get out from me being on the news and getting them to go in there. And so that was challenging. And we had this one person, she's a nutritionist and she's amazing, but she's very shy. And so I got a call from the news. They said, "Hey, Sunday morning at 6 a.m., we've got a spot that we can give you guys 15 minutes, but it's live," which are always challenging because if you mess up, there's not a lot you can do about it. And I called her in and I said, "Hey, I'm going to be out of town," which I really was. And I said, "I wonder if you couldn't help us. And the impact you're going to have is because you're going to get to share how nutrition is medicine and how we can help our patients and all the success stories of helping people that are facing diabetes and things like that with their healthy diet and things." And she was so scared and she did it and she knocked it out of the ballpark. And then now she's like doing more and more of those. And so some of those kind of things happened more and more to where, they're getting engaged and they're starting to learn how critical effective communication is because we can influence patients, we can influence each other, and we can influence legislators with respect to the policies that are changing. And by the way, interrupt me anytime if anyone wants to add anything anecdotally or says like, "Can you go more into that?" Just this is very informal. So the other thing we try to learn is what worked, what didn't work, and how do we improve these things. And a lot of it is in communication. So one of the dilemmas we started facing was AI. So I got an email from one of our managers, and it was pretty lengthy, very well worded, and he promised the world. But he left out that there were some spaces in there that AI had some questions and put some prompts in there. Did you want this and did you want that? So it became obvious that he copied my email, pasted it into AI, got the response, and sent it to me. And so I called him into my office and I said, "I just want to just tell you how appreciative I am of all these things you're going to take on for us. I had no idea that you had a capacity like that." And you could tell he was very shocked. And he's like, "Well, like what?" And I started naming the things that AI said he was going to do. And he's like, "I didn't say any of that." I go, "Let me put it up on my big screen here. Let me show you the email you sent me." And then he ended up seeing, and I didn't do it to embarrass him, but I said, "You have to realize AI is a good tool, but there's a couple dilemmas. One is people are losing their ability to even write because they're dependent on AI, but also you just promised all these things because you just copied and pasted. Where it can be useful is you respond to me in an email and then you paste it into AI and say, can you organize this the best way to influence for this or to accomplish this or whatever?" That's appropriate. And so what happened with that was it created a whole new thing of us putting a very strong policy together for how to properly use AI, because we were also having people not understanding that ChatGPT is not HIPAA compliant. So the AI within the EMR systems are, but if and ChatGPT can be really a great tool. For example, we have our patient relations manager that uses it a lot, that'll describe a patient's behavior and put together kind of a behavioral contract that for us to continue your care here, we need you to be able to refrain from this because of this, and then we're committed to doing that. And it does a great job, but you don't put the patient information in there. And so we put all these things together in helping people leverage AI because we know people use it. The other one would be, when we got the refugee health assessment program, the RFP was like 160 some pages. And then I shared with the team, like, when I uploaded that into AI and asked it to align with all of the things we do at our health center, it helped me highlight what areas that we definitely can do and what areas that we're going to have to improve on or create because we don't have that and the grant requires it. So, there's all these things that we're helping instead of being afraid of technology, leveraging it. And the same goes for students because I get students that I know do the same thing where they're, using AI for everything and helping them understand that there's a strength in AI, but there's also risk in AI. So that's been some other good conversations. But the manager that did that time, he had told me, he said, the reason I started using AI is because every time I send emails, I'm not good with grammar, and people would make comments to me, and I felt embarrassed because I don't have good writing skills. And I said, and that's totally valid. And that's why AI is understanding. AI doesn't care that you have poor grammar because AI is designed to help fix that. So that's where you put your thoughts in and what you're planning to do, what you would like to offer, and then you can have AI help correct it. And so that's been an ongoing battle. And then on the other side, we've had providers that are older that are resistant towards using AI in the EMR where it's listening into appointments, where it actually chops their charting time, probably by 40, 50% in some cases. And so in that case, we had to say, would you agree to do one patient a day? Just one patient a day, do it through the AI. It's called Suno, just one a patient a day and see how that works. And then gradually they started actually adopting to it and saying, this is a lot easier. Whereas pre-COVID, I would have been prone to just write out an email and say, effective immediate, everyone is required to use AI using Suno for your EMR. And so the growth that I've had is to learn that I can force things all I want, but I've learned that my evidence of me being effective is more found in my absence than my presence. In other words, when I'm not there, are they willing to run with things, or do they have the values that we all share that we can make things happen and do things smarter, not harder? Things like that. Um, Whoops, why is it not letting me go there? Okay. Other things I think, emotional intelligence, we've been having to do a lot of training on that. A lot of young people have asked, what is emotional intelligence? That sounds kind of stupid. And I'm like, well, it's not so stupid. So we've gotten a lot into that, and also conflict resolution, and the different, SBAR, the huddles, shared dashboards, but a lot of trying to build trust and collaboration across disciplines and helping people learn to be more forgiving for each other, understand that we have, like, for example, people that have speak many different languages, that at times they may have a challenge with some English, and they can speak three or four languages. Many people only can speak English barely. And so we have to say, hey, don't worry. We're awed by your ability to connect with all the different cultures that we have. So, recognizing each other's strengths and saying, we're lucky to have each other. Real world practices, interprofessional competencies. We have a partnership with UCSD for their medical school. And it's been really amazing because there's been some changes in medical school. In fact, I was talking to somebody from a medical school back east, and they told me that they are asking their students to stop telling people they're a medical student and to say they're a doctor in training. And I thought that was interesting. And then they told me the story of how that came to be, that a lot of people didn't really understand what is a medical student. They were saying people were thinking it's a student in a medical clinic, that's a student or whatever. But there's a lot of evolution within in the medical schools, because it used to be that the doctor was drilled in them that this is your license and you're on the hook for this. And so there was not as much of a team dynamic. Whereas now there's much more embedding of doctor understanding. I can't afford to communicate effectively with my team, and I can't afford not to have them help me be at my best, so I don't have wrong site surgeries, or if I don't have medication errors and all the different things that put a doctor at risk. So there's so many things that are shifting, and some of it also is the changing generations of physicians, that some of which are more willing to accept some of those changes than some of the older physicians that were a little resistant towards that. So that's been pretty interesting. And Sharp's done a lot of work in that as well with their Physician Leadership Academy. Um, but then also leveling the playing field of, there used to be a lot of hierarchy of, doctor, and then you're just an MA and you're just a this, of everybody really understanding how critical their role is. So for example, what we try to do, we have a EVS person, environmental services, which is people will say, "Oh, that's just a janitor." No, that's the person that's going to keep us from having patients get sick from things not being cleaned properly. And so, for that person, it's important for us to make sure they know we're dependent on you to keep things so clean and disinfected so we can keep our patients safe because they have compromised immune systems, and your ability to do that is amazing. So trying to really help people understand the why rather than just the what that they're doing. Um, and some of the developing interprofessional competencies during grad school, that's at that level in grad school, but it's very different for staff that we have, like MAs or people that have not been to college. They relate very differently. Um, and we've done a lot of simulation-based learning and case-based learning to where people can see things, or we debrief things when situations happen, so that we can understand, how did we respond to this? And an example would be during COVID. When I first got there, we had a big dilemma with the opioid situation, where patients were being given these medications far more than they should have been. And I had come from Kaiser right before that, and Kaiser was dealing with that as well as across the whole country people were. But when we had to start tapering patients and shifting from a long-term therapy model to a short-term, it was very hard for patients because they were used to just getting their medication. And so we had on one case a patient that called and said, "I'm going to come there and kill everybody. I'm going to bring a gun, and you'll see, what you've done to me because you won't give me this medicine." And so when that happened, immediately called the police. We did a lockdown, and there were sirens. And so I was outside, and all the staff were inside behind, closed doors and everything. And I hear sirens coming, and the sirens, because this patient actually lived not far, just a few blocks away. And he was on his way down there, and the police intercepted him, and he ended up getting tased, and it was like a real serious thing. That incident, for example, we kind of leveraged that because it was so serious, of how interdependence, how we all need each other, and how that psychiatrist that was the target of that, how she was so appreciative that everybody rallied around her. In the organization, that we got a restraining order immediately, that we would escort her to her car, all the different things, that went on. But I saw that for the first time in the organization hit people, where people were like, we actually need each other. And I think that's another component, that wasn't something that happened on purpose. It was a situation that we just kind of saw that evolve. And then we started saying, we need to communicate this so that we can leverage this more, so we all do realize how interconnected we are. So that was a really interesting situation. Cultural humility, equity, ethics, the other things that we had experienced is all the differences in people. Is we had someone one time that we had a patient came that was misgendered purposefully by a staff member that had deep beliefs that did not like that, and they kind of pushed it. And that became a real issue that we had to address, because one, obviously what it did to the patient, but also for us to start realizing that there are different beliefs within our organization, within every organization, but we have to come to a common ground and have standards. And what role does ethics, equity, cultural humility, how do we help people? And one of the things that surfaced during that was, we all know the golden rule: treat others how you want to be treated, but we changed it up to treat others how they want to be treated. And that became another thing, to where there was discussion and staff, we had focus groups, and they would be able to connect with each other, learning, how do people want to be treated? Do people want people talking bad about them? Well, of course not. But I think all of those things start getting into that interprofessional success, but also knowing the fact that we all are working together, 5 days a week, 8 hours a day. We want to help each other go home not stressed, not have people go home saying, I dread going to work tomorrow because so and so is being mean to me or being ornery, things like that. And those things do happen a lot in the workplace. So takeaways, for me and for most of our leaders, is learning to be really adaptive, mission focused collaborators, learn how to build high trust relationships, And in that, there's so much that you can unpackage. And I wanted to share a couple just anecdotal stories. So when I was at Scripps, I weighed, I think, 247. I was at my heaviest. And I went to get a physical, and the doctor said, well, you need to lose weight. And I kind of looked at him like, oh, really? I didn't know that. I didn't know that. But I said to him, well, you're bigger than me. What about you? And he was like, why would you say that? I said, well, why would you say that to me? And I knew this guy. So, and then he said, well, what would you have wanted me to say? And I said, okay, maybe if you would have said to me, so Kevin, walk me through what are you looking for quality of life? Like, what do you like to do? I would have told you hiking and things like that. And then you could have said, are you ever worried about maybe your knees or things like that? And we could have had an interactive discussion. And then you could lead me to, there's certain things that you could do, and I could be supportive. And hey, I too struggle with my weight. We could partner in this. And I remember that conversation, and it resulted in me dropping down to like 185 and over, I don't know, probably about a year. And then I've been able to maintain it. I'm now about probably 195, 200. But it was interesting because what I was looking for is not someone to just tell me that when it's only obvious. You think I didn't know that? I wanted someone to tell me I have a hard time too. So I've always shared that story with providers to talking about don't see a patient as this is patient number 3355. This is a person. And if you can humanize yourself, it does huge things in helping us. And then the other thing is sometimes miscommunication. So um, I had something happen to me recently. I had my annual physical last week, and so part of it was an EKG. And so I get a call from the doctor, and he's like, yesterday, and he says, I need you to come in. I'm really worried there's something going on with your EKG. And so he goes, and I asked him, well, can you tell me over the phone? He's like, no, I need you to come in, which made me a little bit worried. So now I started having chest pain and heart attack. I'm just kidding. But anyway, I get there and he starts telling me, I think there's some blocked valves. We're going to have to do a stress test. We're going to have to go in. And he's going into all this stuff. And I'm just like, and he's like, how long have you been having chest pain? I'm like, I don't have chest pain. He's like, what about the shortness of breath? I'm like, I don't have shortness of breath. Well, anyway, I said to him, honestly, I think you should send me over there for another one. I just, this is weird. And he's like, well, no, they're good at what they do. And I go, no, I really insist. And so he said, okay. So I went over just down the block to the other clinic, got an EKG, and then he called me about 2 hours ago and said, it was the EKG was not accurate. They didn't put one of the leads right. And I'm just like, oh my God, are you kidding me? But things like that happen all the time in healthcare, and it also happens all the time with staff communicating with each other. Another example was a patient a while back called and complained. They said, I was on the phone with one of your staff, and they had these big long pauses. I had to keep asking, are you still there? And so when we talked to the staff, who's early 20s, um, the staff member was like, well, yeah, but I was looking things up. And we were like, okay, but maybe what about telling the patient, if you don't mind for a minute, you're not going to hear me for a second. I'm going to pull some stuff up for you, okay? Something like that. Well, this person says, well, I don't mind when people do that to me. And so there's this with the younger generation, there's a lot of this is very recurring. And so what we had to do is a simulation and have the quality manager basically simulated and was the one taking the call, and this person was going to be the patient, and then basically simulated that and did the exact times that it showed on the audio of how much time there was just dead time. And then the person was like, I didn't know it was that long. Yeah, I guess it feels that long when you're actually not doing something. Whereas in a lot of cases, people would just tell someone, why would you do that? That's not acceptable. Don't do that again. Where now we're learning that we have to actually show someone what does it feel like because they don't connect with that. So I don't know if anybody can resonate with some of that, but it's just, for me, it's being a curious learner because we keep learning all these different things of how do we try to solve problems? How do we do more with less? How do we get all the generations to appreciate each other? Like when I was at Kaiser, they had a big dilemma with knowledge transfer. So the baby boomers were getting ready to retire in large numbers, and they were not good at knowledge transfer for the younger nurses. And has anybody heard the term "the nurses eat their young"? Anybody ever heard that? When I heard that, I was kind of shocked like that. What does that mean? But nurses will tell you that. They say, yeah, well, we eat our
Yeah,
young. What it,
yeah,
it
I
just
heard that.
basically, yeah, when the new nurse comes in, you're doing the grunt work. You're doing the nasty stuff because I've done my time. And so we were doing a lecture with all the generation of nurses. It was a pretty large crowd. And so we're asking them, okay, everybody, don't get offended, but let's let everybody share what their challenges are with each of the generations. And it was kind of comical. People were having fun with it, but you could tell they were real with it. And so, they were saying like, these Gen Y, the millennials, they want to come and work for 3 weeks and be promoted, and they were just going into all this stuff. And then the others were like, the baby boomers, that they don't know how to talk to us, they're not respectful, this and that. Well, by the time at the end, we asked a question and we said to the baby boomers, raise your hand if you're getting ready to retire, within the next year. And huge numbers raised their hand. And then we said, raise your hand if you're going to be the nurses caring for those baby boomers that are going to be needing you the most. And then all the young people raised their hand. We were like, isn't it your interest to be mentoring them and to doing everything you can rather than eating your young? And it had a big impact, but it kind of took that kind of connecting and walking through it. So I kind of wanted to open it up for dialogue now. Um, this was a long day for me. One last quick story, the mobile unit you've heard about. I keep talking about another communication dilemma with a regulator. So we get it's a $500,000 mobile medical unit, 35 feet long, high tech, amazing, amazing device funded by HRSA, Health and Human Services. And we get this unit comes here and we're using it, and all of a sudden some two agents from the state of California show up and they want to see the CEO, and I come down there and they go, you're in violation, we're citing you. This vehicle is illegal to be in California. And I'm just like, what does that mean? Like, what do you mean it's illegal to be in California? Well, the vendor that makes these units for California and other places, a law had just changed that restricted this particular model, Dodge Ram 3500 or whatever it is. And it just happened to coincide where the vendor didn't know, no one knew. Well, anyway, I'm like, okay, so you're telling me now, they said you must get this vehicle out of California within 30 days or you will be fined. And it's all on your name. This is on my name because it has to be a person. And so I'm just like kind of stunned because we're taking it out, using it for underserved populations and everything. And so I call Tony Atkins, I call several other people, and we start kind of putting our heads together. And this was in 2024. And so the state agrees, like, yeah, okay, we get it. Okay, you guys continue doing what you're doing, and we'll figure a way around this kind of a thing. So I don't hear anything. And so January of this year, I get a call from one of the head people up there, and they say, you're going to be getting a letter from us soon. Okay, great, and never did hear from anyone. And again, I confirmed in the email, confirming we still can use this unit to see patients. Yes, okay. Well, I get a letter today at 3 o'clock, or no, 2:30. I get a letter today from the state saying you owe us $6,000 in fines, and you must get that vehicle out of California effective immediately. And I'm just like, what? So I had already had a letter drafted when the guy told me this was coming, and I really put it together well, exciting all the things that had happened, the regulations and the way the timing was, all these things. So I had it almost queued up, but I read her letter, I put somewhere and I sent it, but I CC'd Tony Atkins, governor's office, Indian Health Service, everybody I could think of, because if we lose that unit, people would actually, and urban Indians, ours is the only clinic for the county that can service them. So we would actually tell all of them you have to go to LA to get care, which is absurd. So I sent this scathing email. It was kind of being nice, but also ceasing all these people. And then I thought to myself, just pick up the phone and call them. And other people were telling me, no, don't, because anything you say could get, this, you could get in trouble, this and that. So I pick up the phone and I just call the number that's on the letter, and the lady answers. And I'm like, hi, this is Kevin. You probably saw the letter I just sent. And she's like, yeah, we're a little taken back. And I said, well, I'm not sure where this is all coming from, and I told her the story of everything. Well, within 45 minutes, the state agreed if we pay the $6,000 fine, they'll release us and we don't have to remove the unit. We can keep the unit. But it happened in a matter of a 15-minute phone call when we were ready to start getting attorneys involved and everything else, which was just interesting to me. And then I got my blood pressure started going down a little bit. And then I called the vendor and said, we have restricted funding. Would you be willing to pay the 6,000? Because technically we could have an action against you because you guys sold us the vehicle. And then they said, yeah, yeah, that's fair. So it worked out. And my point of that again is somehow trying to be able to communicate through humility. Because when I once sent the letter, I'm mad, I'm angry. I'm like, I can't believe they're thinking they're going to do this. But it probably served its purpose because it did. They were kind of like, oh my gosh, we didn't know all these agencies were involved. But then by calling up, and then she's like, well, I just talked to the higher ups, and what if we just did this? Would you be willing to do that? And I was kind of taken back, like, well, is this in writing? You will do this in writing? Like, we would have to have this, in writing. Yes, we would send you a letter we release. Okay. So I just, and I share that because it's so dynamic. Like, even with students, like I learn every day what are more effective ways. We all do. And it's just this curious learning that we can do and become better and better until things change and we have to learn new ways again, that constant evolution. So with that, we got 15 minutes so we can just kind of chat and questions and answers or dialogue. I threw a lot out there, so I know I went a little fast, but
Thanks,
Right.
Kevin. Really appreciate that.
Dr. Lachapelle, I kind of understand and appreciate that story you told about the nurses talking about the old ones eat the young one, and I've heard a similar story actually from the young ones. Uh,
okay.
yeah, it was saying that they were being poorly treated for some reason they knew not.
Yes.
But eventually it came to an understanding that the senior nurses indeed needed to ensure some type of peaceful transition when so this whole idea of mentoring younger nurses became a more important focus on how to resolve the problem that they were having historically. Um, yeah.
Yeah, it has so much impact, especially,
It's
you know,
about I think it's about initiating a conversation
I think
instead
so.
of a conflict. It's always about having that conversation, getting it going.
Which is hard because when I called that lady today, I was ready to fight. I mean, I was so
Yeah.
dang mad. I was like, "You, how dare you send us a letter like we have refused to get rid of this vehicle?" And then it was her humility that then brought, because I could tell she was kind of nervous, like, "Oh," and then I'm like, "Okay." But it is hard because our emotions get involved. But you're talking about the nurses. We had a nurse one time that she wanted to leave. She put her notice in, and our HR director was able to kind of talk to her, and it was from being bullied by one of the older nurses. And that when
Mm.
remedied it, she ended up staying. And I wonder sometimes how many people leave that we never knew what the problem was because they just kept it to themselves. But we lost them, and then now we have to pay the money to get a new nurse all trained up, ready to go to be bullied potentially again.
No, it's something else too about when you actually consider, I'll call it the leadership challenge. I know for some time, for example, when you had the issue with the doctor telling you to lose weight as opposed to, again, having a conversation with you.
Yeah.
Uh, it I think it's cultural, and there's a lot of verbiage being passed around. One is cultural competency,
Mhm.
and I think we're in that season or in that era where it becomes, I think, common language and a common practice now that we call collaborative. There's these collaborations that are going to be important for us now and in the near future to particularly when we start looking at what's happening with I'll call medicine virtual, virtual, we're moving to a virtual healthcare environment. where conversation has to be the central part of I think of healthcare. And when you actually think about the mental, physical, emotional
Yeah.
connection, got to have conversations with on clients with people.
Yeah, there's this patient when I was at this one health system. She's now 93 years old, and we killed her husband through a series of medical errors. And instead of suing, she wanted to be put on the board to help make improvements in healthcare. And that's how I connected with her. And this was just so long ago, and we do speaking engagements all the time together. But I've had her share with students. And one time it was a quality class, and I had her share her story of what happened to her. And the students were so taken back because it was a raw story from the person that it actually happened to, that if I would have told it, it would have meant pretty much nothing. But I think that also being able, the art of storytelling, where people like Reggie felt empowered to tell her story because she knows she's changing the face of healthcare through students. And so that's the win for her. And then the students got to hear from a grandmotherly person who's sharp as a tack at 93 years old. And I mean, she was telling them so much about the health system, and she's non-clinical, and yet she knows everything about quality and stuff. And every time the students always would give me feedback saying, I hope we can do more of that. And so I think that kind of stuff, that communicating. The other one was, we had a patient one time that said, I'm hard of hearing, and your patient or your staff, because I talk loud, they think I'm yelling at them. And we actually let her make a video talking about it, and we shared it to all of our staff. And, you know, things like that can be innovative because it was empowering for her, because now she knows she got not only got heard, but she got to actually have it shared with all of us. And then the staff get to say, "Oh, I know who she is. I always thought she was just yelling. I didn't know she was hearing impaired." So it's just interesting, those dynamics. And I do kind of see that that is such a way forward in so many ways. But some people are resistant to it. Like, when that lady, when I played the video, we definitely had two staff that were sitting in the back, just like, give me a break. And it was interesting to see that, because the majority of people were actually like, I didn't know that about her. And then the two that were like that, we ended up having conversations with them later. So, you seem kind of a little irritated, like, walk us through that. And then they were like, because she's mean. And then we started talking about, do you know her prognosis? Do you know what she's been enduring? And so it's easy for us to say that, and that happened at Scripps. One of my first interactions with the patient at Scripps, a lady came in to get her medical records, and she was upset, visibly upset, and not very nice. And the person said, "I'm not going to give them to you until you can be nice and talk to me nicely." And so the lady just went in the lobby, started screaming, "These people won't care." She went on. And then so the medical records people call the police. So I walk in. It was actually my like second or third day. I walk in, and I'm seeing this, and I encounter the lady right away, and she's yelling and screaming, and I'm like, "Man, what happened?" And she's like, "I can't believe this." Well, anyway, she ends up telling me she had just gotten a diagnosis that was really bad. And she wanted her medical records because, one, she's kind of in denial, and kind of like I was today with the EKG. She wanted somebody else to take a look. And when she went to the medical records people, the person had an attitude, and the person was taking forever and said, "Well, why do you?" It was questioning her, like, "Why do you need these?" And then when I walked over to her, and I was brand new to healthcare, so I didn't know all about HIPAA or anything, and I just said to her, "Is the patient entitled to these records?" "Yes." "Then give her her records." "Well, if she's not going to be nice," says, "listen, we'll talk about this later. Right now, give her her records." And I'll never forget that, because afterwards, when I told her, "Why do you think she was upset?" And I told her she had been just delivered a very serious prognosis. "Well, I didn't know that. She should have told me." I said, "No, it's not her place to tell you. You have to be empathetic. Most people that are in a hospital are in crisis. Why would you think people hang out at the hospital? Or could they go to a clinic to just hang out and get a coffee? But that mindset is very strong in healthcare. And I was at a conference one time when I was at Prescaney, and this ED physician, he made a statement from the podium. He was speaking to, it was a large audience, and he made a comment, and he said, we need to change it from patient-centered care to person-centered care, and I'm part of that person. And if patients want me to be nice to them, they damn well better be nice to me. And I was kind of like, okay, if I come in a trauma situation, I hope I can be nice, but if you're pulling and prodding on me and sticking needles in me, I'm probably not going to be very nice. And at the break, I went up and talked to him and I asked him, I said, I'm just curious. I don't know how good I would be. I'm kind of afraid if I came to you, you probably wouldn't like me because I don't know if I'd be that good if I had a real serious health issue. And he's like, well, people have to realize if they want the doctor to treat them, then they have to be nice. And it was shocking to me to hear that. And he wasn't, I didn't know him, so I couldn't even further discussion because he hunkered down and basically said, he said, no, that's why there's physician burnout because of all these patients. And the last thing I said to him was, I said, my sister, she's a nurse and she's tired of these patients too. And she did the right thing and she's now a nurse educator. I said, so sometimes if it's too much to be around patients, it's probably time that maybe there's other options of, where you can be your best. And I walked away. I don't know if that seeped in, but that was surprise for me to hear that. But I have heard a lot of people in healthcare, even at our clinic, where when a patient's upset, they immediately like, we should tell them they have to leave or we're going to call the police. And it's like, okay, why are they upset? And then when we look at the why, then we kind of go, oh, I'd probably be upset too. So like to your point again, that dialogue connection.
Thanks, Kevin. Any other
Well,
last questions here?
I'm grateful for the opportunity to connect with everybody. So thank you for that.
Well, I'd like to thank everybody for attending. We'll be putting this up on our YouTube channel, so give us maybe a couple weeks because we do have a kind of a new account where we're uploading these in. But I really appreciate it, Kevin, and thanks to everybody, especially from the department, for showing up today for the School of Health Professions Interprofessional Education Committee. Our probably next presenter will probably be February, January. I'll be a planning meeting with our committee. So thanks, everybody. Happy holidays.
Bye-bye.
All right, be
Thanks. Bye,
well. Thank
everybody.
you, Dr. Lachapelle.
Thank
Take care.
you.
Thanks so much. Love the stories.
Thank